Με μεγάλη χαρά θέλω να καλωσορίσω στο βήμα τον τρίτο μας ομιλητή, τον συνάδελφό μου στο Εργαστήριο Εμβρυολογίας του ΥΓΕΙΑ Εμβρυογένεσις, τον Dr. Steven Davies, που θα μας μιλήσει για τις ενδείξεις κατάψυξης ωαρίων και εμβρύων.
Hello, good evening, good afternoon, whatever time it is. I'm going to give this presentation in English. I hope it's okay for everyone, so I can, make clear what I'm trying to get over. Thanks for the invitation. This meeting, for me, because we're stuck in the IVF lab looking at the embryos, we don't get much access to the clinical information and the clinical side of this. But what's infuriating from an embryologist's point of view is you deal with these cases and we see the eggs, we see the sperm, we create the embryos, and then we've got this group where we put the embryos back, this unexplained infertility group, which now is opening up, and it's obviously becoming, it's been slowly eaten away with information coming from you lot, filling in the gaps of why the embryos, why these patients are not getting pregnant. And, over the 35 years I've been doing this job, the unexplained infertility group has slowly been reduced. But we generate these embryos and then we throw them back and the doctors throw them into an open space and they come back with no result. And it's infuriating because, that gap in the middle that we can't bridge, we are generating these things and the doctors are putting them back. But the information in these meetings is, for me, phenomenal. I love it. I love it. And it's giving me answers to a lot of the questions we have every day. So when I started looking at this, because we deal with over 35 years, it's very difficult to say if I've personally ever dealt with a patient with rheumatoid arthritis. And the more you look at the information, as you dig into the information, there's not much information available. We deal every day with things like lupus, we deal with Hashimoto's, we deal with Graves. We have a lot of information about, and a lot of requests with multiple sclerosis. Should I have treatment? Should we go down this road? But the rheumatoid arthritis, I can honestly say, on a file, I've never read this, and I've never understood a patient has come for treatment with rheumatoid arthritis. So, as I was looking at the thing, it's important for me to put things in perspective, what these diseases are, what the thyroid problems could cause, and the other ones which, create endocrine problems. But the rheumatoid arthritis, why is this a problem? Why is this a subfertile, probably not an infertile group? Why is it a subfertile group with a lower AMH overall than the normal population? Where do these things come from, and what can we do about it? So, for me, going into this subject, just understanding what the problems are. You say, why is this person subfertile? It's a disease affecting joints. It's not really an endocrine problem. It's not really anything which is associated with infertility or with the endometrium or with the ovarian production. You look at the symptoms. You say, okay, this problem is probably more of a social problem. They, have lower sex drive. They have more physical problems than anyone else. Why are they subfertile? Why are they not having children? Why is a group they're having less children than the normal population? So, the information coming out is very, very low, and it's a very grey area. They have a lower AMH. Why do they have a lower AMH? Why about this? They appear to have no other problems apart from a slightly lower AMH. They're usually older. Once this disease starts to appear, they're usually older. They're not young patients. It's an age-related problem. So the women, mostly women have the problem. More women have problem of rheumatoid arthritis than men. And once this becomes obvious, obviously, you know, she's getting on to the later stages for fertility cycle. So we need to look at the drugs. The drugs they're taking, do they affect the levels of AMH? And each of the studies, again, the studies are not so large and they're spread all over the world. A lot coming out of China, a lot coming out of Japan. So if you can rely on the Chinese data, it's difficult to understand. So the drugs they take, because they take in the drugs to control these diseases, you know, does it have an effect on the AMH? And it's probably not. You know, we go to the next slide. So we look at, in general, the AMH levels, and any studies that they've used looking at the drugs they take in long term with AMH, there's no correlation. So the AMH has been reduced from something else. This has come in with the methotrexate. This has come in Humira treatment, which is, you know, sometimes used in combination in this disease. It's actually been used as a drug in IVF in a centre in London, Daranisi, where they've actually found it helps increase the pregnancy rate. So, you know, these drugs are not toxic. Methotrexate obviously is a problem in the pregnancy, but, you know, they look at the ovarian reserve in children taken from juvenile onset. Again, the AMH levels are not affected by the drugs they're taking. So why do they have slightly lower AMH? It's probably to do with other factors, inflammation factors or something else associated, but it's not to do with the drugs they're taking, which is good. And unlike all the other diseases we're looking at, you know, the Hashimoto's, the Graves, all the drugs they're taking are problematic for their fertility. At least in this case, it's not the case. So if I just take a step back here, there's one part with, it might cause some anovulation, so there could be a block of ovulation, which is not being detected, so the patient could be assessed as normally fertile and ovulating, when in effect there's some block of ovulation, so then they're subfertile or infertile because of this, but it's quite rare, apparently. And in general, this group of patients are not a group of patients where you would need to use fertility preservation. So it's probably the one group within this group of autoimmune diseases where you don't really need to go ahead and start freezing eggs, embryos, or any other ovarian tissue as a fertility preventative method, because these patients can undergo IVF treatment. So the fact that do we need to go down the road of freezing for these patients is probably not needed, because they can undertake normal IVF if they make the decision, and they're young enough, obviously. They can take the drugs as a normal IVF patient. They have the same risks and problems as a normal IVF patient, but they need to have stopped the treatment beforehand, so they need to be under control for at least 6 months before treatment. And then the outcome is, as you know, anyone in their age group for IVF. If I get a look here, maybe somebody disagrees with it. So it's, you know, they can undertake the fertility treatment, but everything needs to be under control. So the patients which do the best on fertility treatment, take in the stimulation, they need to be under control for 6 months, and then they're okay. If they're not under control, then the outcome is not so good. So So can I have treatment? Obviously, yes. They may need to test negative for antiphospholipid antibodies if this is a problem in a subgroup. But all the rest is, they can use stimulation protocols, and the time is not really an issue. It's just the age is the issue. So because of the age, and if they don't have a partner, they can undergo the treatment, and eggs should be frozen at that stage, which is possible. The number of eggs need to be frozen is obviously to do with the age. So if they're around, if you're a patient around 40 years of age and you need to freeze your eggs, for a 50% chance of pregnancy, you need at least 20 to 30 eggs frozen. So the numbers are large. Better if you've got a stable partner and you can freeze embryos, then you can freeze 5 to 10 embryos and have a good chance of pregnancy. The pregnancy is the same in this group of patients as your normal groups of patients, as long as, again, I said, everything's under control. The problems can come later with the pregnancy. There can be preterm deliveries and slightly lower birth weights. But in general, the problems are not so great. But it's just, when they can make a decision, when to go down this road, because probably the information comes at a later stage in as they get in 40 plus, and there lies in the problem. So the adverse pregnancy outcomes, if you look at it's really, after you compare it to lupus, for example, here, what you're looking at is the risks are much reduced from all the other types of Hashimoto's, from lupus and all these. The risks in the pregnancy are much reduced, and they're not so important. So again, it's all the data shows it's just slightly lower birth rates and slightly preterm pregnancies. This is the main problem with this group. And again, it's something which, if you know, can be controlled. So the decrease in the fertility with this group is probably more associated with inflammatory factors in the endometrium, in the implantations, than the drug side of it and the problems with the disease itself. So it's a subgroup of these autoimmune disease which has a much better outcome for patients than virtually all of the others. So my conclusions are that there is a subfertility suffering from these diseases. The drugs used can control the disease but need to be stopped before trying to get pregnant and before pregnancy. Obviously, the methotrexate is a problem. The IVF treatment is as successful as the patients in their age group. So a 40-year-old woman has a 30 to 40% chance of getting successfully pregnant. It's just the problems, with the social aspects of this, the disability that this disease brings is probably the most important in the decision to go ahead, not infertility problem and risk of the drugs, which they have to stop. And cryopreservation can be used, should be used, if they don't have stable partner, if they don't want it today to help that timeline, but really only the same decision that somebody would make for social freezing. There's no reason for this disease to go down the road of freezing, ovarian tissue or eggs if they don't need to freeze the eggs. Freeze embryos if they've got a stable partner, or freeze eggs if they have to try and save, the the chances of getting pregnant at a later stage if they haven't got a stable partner, but no other reason for that. Okay, thank you very much for your time.